I have the pleasure of introducing Dr. Hannah Morton today, who has really helped to coordinate this panel. Dr. Morton is an autistic postdoctoral fellow at Oregon Health and Science University, following completion of her PhD in clinical psychology from Binghamton University in 2021. And her research examines the unique social experiences of autistic and neurodivergent youth, as well as the overlap and distinction of autism and ADHD. Hannah also maintains collaborations with several cross-institutional research groups, focusing on valid and meaningful outcome measurement in autism research and clinical practice, as well as the inclusion of affirming language and autistic voices within the field. So I am going to turn this over to Hannah, who is going to introduce our panelists and give a short background before we get into our discussion.
Thanks, Kara. Sorry for the mute. I'm really excited to be here with everybody today. And so we're going to be moderating this panel. We have 6 fantastic panelists that are going to be joining us, ready to speak about their experiences. And to get us all set up and ready for that, I just wanted to give some background and set the stage for what we can expect. So we're going to be providing some context to you first, as far as the background of autism and ABA, some literature and perspectives that we can all learn from and get us ready to be having these conversations. And then also discussing some guidelines for how we want to make sure that the panel runs smoothly and that we're respecting everyone's views. And then we're going to get into the panel itself, which is going to be the main focus of what we're here for today. And we do have some structured questions that our panelists have seen in advance and that they will be answering questions. We also, if there's time, we do have the option for a Q&A at the end, and that will be questions that are submitted from you all. And we ask that you send those directly to Kara in the chat, and then she'll be able to filter through and pick ones that hopefully are most representative of the views and the questions that all of our audience members have today. We will have a 10-minute break at the end of that structured panel portion. And then if you're able to stick around, we will be randomizing into smaller groups for discussions. And we do have about 10 to 12 small groups, so they're going to be small. So hopefully real opportunities for us to continue these discussions and participate in really thinking through these topics. And I do just want to add a trigger warning to some of the content that I'm going to be sharing, and even the discussion that we're going to be having today, that this discussion of autism history and therapeutic practices, it does include a history, right, of harms to autistic people. And so, you know, if you need to take a break from the panel, you know, turn your video off, all of those things are acceptable, and whatever feels right for you is right. So to go through the brief history of autism and ABA, many of you will be familiar with and know that the origins of autism sort of began when Leo Kanner started describing infantile autism, which he described as a psychiatrist and physician at Johns Hopkins Hospital, as youth who had a powerful desire for aloneness and obsessive interests on persistent sameness. And Hans Asperger, around the same time, was in Austria, and he described some children with the term autistic psychopathy, and describing similar features, a lack of empathy, little ability to form friendships, preferring one-sided conversations, and being absorbed in special interests. And then we know that the second edition of the DSM was published in 1968, and autism wasn't considered as a separate category, right, within that field. It was more so just mentioned within the description of childhood psychosis. And so autism at that point was really described as autistic-like behaviors or withdrawn behaviors. It was largely associated with intellectual disability, and it wasn't viewed by the community as a separate construct. And around that same time in the 1960s, ABA, or applied behavior analysis, was being developed as an approach at UCLA. And the idea here being that autistic people at this time were viewed as not really being able to learn, and there wasn't really a very good understanding for what autism was or was not. And so ABA evolved as this learning theory and this approach that would allow autistic children to be able to learn and hopefully to keep them out of institutions for some of these behaviors that were really unsafe, like aggression and self-injury that couldn't be accommodated within these lower systems of care. And so then we can move that forward to more recently, the DSM-3, where we saw that autism was first included within our diagnostic characterizations. And some increased distinctions were then made in DSM-4, labels like autistic disorder, Asperger's, and PDD-NOS. And these labels really started becoming more known and more relevant to the medical community and to the psychology community. And then in 1998, an Australian sociology graduate student named Judy Singer coined this term neurodiversity, which she referred to as being neurologically different. And it was in addition to more familiar categories, for example, of class and gender and race, and ways that we already recognize that people are different and contribute to differences in society. And then in 2004, sort of spanning on or expanding these neurodiversity arguments, Michelle Dawson wrote a critique of ABA that was published, and really stating that it was unethical for ABA practices to be implemented, that they weren't based in science, that they weren't based in these evidence-based practices that we would want to see. And so there was a trial in British Columbia where the court sided with her opinion that she testified, and stated that the Canadian government would not be paying for ABA as it was not an evidence-based practice. And that was one of the first times that we really saw these critiques against ABA start to come about, which then have expanded, which we'll talk about more in a minute. And then most recently, we know that we have the DSM-5 published in 2013 with this characterization of autism spectrum disorder. So most of the work done to diagnose autism and to provide therapy and interventions for autistic people has been within this medical model, and that includes ABA therapies. And within this framework, we focus on deficits and impairments, and we view that there's pathologies that need to be changed or need to be fixed based on a certain number of symptoms that will be present. And that also a view that there could be severity levels, or that someone could be more autistic or less autistic based on the number of symptoms that they have, or based on how severely they're affected by these characteristics. But an alternative to this is the social disability model, which was proposed by Oliver in 1990 and suggests that autism and these other disabilities are not necessarily in themselves disorders, but that they're more so disabilities based on the way the society is set up and based on the barriers that we see in our day-to-day lives. And so these are things like if your environment is not accessible to you, attitudes that other people might have towards you, and the ways that organizations and systems are set up to not be inclusive or accepting. And within this model, people start talking about support needs rather than talking about severity levels. So as we think about how this history and context applies to our panel today, something we've been thinking a lot about in preparation is what we're actually talking about when we say ABA. So broadly, ABA is a scientific approach. It's based in operant conditioning principles. And within this approach, practitioners identify environmental determinants of behavior, and we are altering contingencies to change observable behaviors. And there's many techniques that are based in this learning theory. This involves identifying environmental determinants of the behavior or when the behavior is happening, arranging motivational operations or the function of the behavior, altering the antecedents within the environment, and then manipulating the consequences of the behavior, such as through strategies like reinforcement. And ABA has been used in many different fields. So it's actually not an autism specific approach. It's been used to support and treat substance use, eating disorders, dementia, and also largely underlies a lot of the approaches that we see within the industrial organizational psychology. And specific to autism, which is perhaps the most widely used approach or the most common or well-known approach, the ABA principles are used to try to build language and communication skills for autistic individuals, to build adaptive skills and social skills, and also perhaps more notably for behavior reduction, which is addressing behaviors that may have serious implications for harm, such as aggression or self-injury, also used to address noncompliance and repetitive behaviors. So given that background and overview, I thought it would be helpful to summarize some of the perspectives from the literature, and then we also are going to be summarizing the perspectives from our SIG based on the poll that we sent out. So support for the use of ABA in autism includes that it's touted largely as an evidence-based practice. It includes individualized selection of goals and intensity, or the hours of service delivery. And some reviews and meta-analyses have found evidence that ABA delivery increases IQ, language and daily living skills, and socialization skills for autistic youth. And there's also evidence that ABA techniques can reduce behaviors that pose immediate danger, such as aggression that injures others, or high rates of self-injurious behavior that can cause permanent physical damage. And proponents of ABA reform also often highlight the shift or emphasis on using positive and reinforcement-based contingencies, and the shift away from punishment or other harmful principles that are now largely rejected. And an alternative side, moving to the right side of your diagram, is that there is also literature that critiques ABA, or that says that ABA is, moving to try to change autistic-like behaviors, and so trying to force eye contact or trying to reduce stimming or self-stimulatory behavior. And an extension of that, even teaching camouflaging or masking, and which is associated with a lot of negative mental health outcomes. Other critiques include that there's an emphasis on vocal communication or speaking, as opposed to accepting all different forms of communication, and that AAC is only used as a supplement. Critiques also include that there's a priority on compliance, and that compliance and doing the desired behaviors is the priority, rather than trying to understand why an autistic person might be non-compliant or might not be doing the target behavior that's trying to be elicited. And some more recent literature also suggests that autistic people who have experienced ABA may have increased PTSD symptoms later in life. And so there's been some emerging talk about ABA being related to trauma. And finally, that many of the articles that are published in behavior analytic journals are published by authors who have conflicts of interest based on their education or employment or consultation work, and that these are largely undisclosed within the publications. So we also sent out a poll to the SIG, and we got so many overwhelming responses. So 84 responses. So thank you so much to everyone who contributed your perspectives and shared your thoughts here. And this is sort of setting the stage also for where we're coming from, right? And the things that we want to be learning, and how we can be prefacing the discussions that we're going to be having today. So there was some varied perspectives with our respondents and our SIG. Many people feeling somewhat familiar, at least, with ABA, but a little bit less familiarity with the discourse on ABA currently. So in the context of the neurodiversity movement and sort of these arguments and conversations that I just summarized. And then we also asked the current opinion on ABA, recognizing that this is a very broad question. But about half of the SIG supports the use of ABA, and then some varying responses otherwise, about 25% opposed and about 20% with no opinion. And so we followed up with that, asking for some qualitative feedback about the opinion on ABA, recognizing that this is a very general question. And we did get a lot of really nuanced responses. And so I'm just going to highlight a few of those here, including that ABA can be useful in some circumstances when a true functional analysis is conducted. That it's useful in specific contexts if the intervention is aligned with the youth's interest and not just done to conform to social norms. And highlighting that it's necessary that we're listening to the experiences of people who have received ABA therapy, especially those who are saying that it's abusive or traumatic. And a really important point here that came up a lot in our prior discussions is that we don't have another evidence-based intervention or support in place. And so our delivery systems are really highly ingrained within the ABA therapy approaches. And finally, that our SIG members just want to learn more. And this theme came up a few times about just wanting to make an informed decision about which children to recommend pursuing ABA, and just about the recommendations that we're making in general when we're talking to families. And then we also asked what you're hoping to gain from the SIG's pre-conference panel. And I summarized a few themes here. The first one being wanting to incorporate neurodiversity within our approaches. So balancing some of these early intervention efforts and recommendations with recognizing and using a neurodiversity informed approach, understanding the impact of ABA on the lives of autistic people and what changes the autistic community wants. And also balancing perspectives across these positions, right? That we recognize that there's support of ABA and that there's also arguments against ABA. And so wanting to be able to have those dialogues and hear about those perspectives to be able to sort of bridge this chasm that seems to be building between the fields. Finally, some ethical considerations, such as delivering ABA in a way that empowers youth and providing therapy that fits our needs. And wanting to have honest conversations about these ethical considerations and about the potential for trauma or harm that could be done inadvertently through our own or through the actions of others. And then this piece about clinical recommendations came up a few times also, again, about wanting to recommend ABA, using ABA with some interventions, and talking about ABA with families. So with all of that being said, we're going to transition into our panel. And we do have some guidelines for our panelists, but also for everyone just to be aware of. And our panelists did receive this information in advance. And so I'll just go through it very briefly here. We are going to be focusing on using structured questions. So we're going to be starting with a brief 1-minute summary from each of our panelists on their perspective on ABA. And then this is going to be followed by 5 additional questions as we have time for. Of course, and we do ask that we're going to be centering autistic perspectives. And so we're going to be prioritizing responses from our autistic panelists. We do have 3 autistic panelists and 3 non-autistic panelists. And so to create space for that, the panelists have all been asked to allow for an autistic person to be the first to provide a response to each of the questions. We also distributed affirming language guidelines to our SIG and also to our panelists. And I think Kara's going to also add those to the chat as well in case anyone hasn't seen them. But we ask that the panelists and that also as you're asking questions that you consider incorporating these recommendations. The panelists are welcome to unmute themselves or use the raise hand feature. And panelists who do raise their hand, I will create space for them, call on them, and we ask that the other panelists wait to respond until they finished. And that we want to also, create space for differences and that we recognize that not everyone on this panel has the same opinion. And in fact, that's why you're all here, is because you have different opinions and different lived experiences and perspectives. And so we want to be respectful of everyone's opinion and perspectives, recognizing that, our panelists are contributing their time and their energy to be here, and we really appreciate that. And so to that end, we just want to make sure that we are able to share information in a safe space. And that also includes in our discussion breakout groups afterwards, wanting to validate, the experiences of others and not talking over other people. So I'm going to go ahead and go through some introductions for our panelists today. Our first panelist, so sorry. Okay, here we go. Our first panelist is Patrick Dwyer. Patrick is an autistic researcher currently pursuing his PhD in the Neurocognitive Development Lab at UC Davis. He primarily studies sensory processing and attention in autism, but has also been involved in collaborative research, exploring autistic people's views regarding naturalistic developmental behavior intervention practices and the neurodiversity movement and other key issues. And Patrick also added that he has not been a recipient or provider of ABA intervention. And I am going to, Kara, can you read the bios? I just can't scroll down on my screen here. Do you have the rest of them pulled up that you can access without me stopping sharing?
I do.
That would be so great. Thank you so much. Sorry.
All right. And so then we also have Amy Gravino here, who is an autistic relationship coach and autism sexuality advocate in the Center for Adult Autism Services at Rutgers University. So she is also a professional speaker and the president of ASCOT Consulting, which offers autism consulting, college coaching, and mentoring services for organizations, schools, individuals on the autism spectrum, and their families. And next we have Joy Johnson here with us, who is an autistic advocate, behavior analyst, clinical director, and adjunct professor. In her bio that she sent around too, she shared with us that she has personally experienced the ills of ableism, racism, and flawed social validity related to her intersectional identities within the ABA educational systems and society in general. So her mission is to insist in ensuring autistic community members are being comprehensively accommodated, accepted, and supported in navigating the world without compromising their autistic identity. Next, we have Pablo Juarez, who has been a behavior analyst for around 20 years, working across autism and brain injury service fields. So a primary focus of his work over the past half decade has been increasingly guided and shaped by substantive engagement and partnership with those communities that they are serving and supporting. So with regards to ABA, his team has developed a model for service delivery, which was and is directly informed and guided by relevant community partners, including autistic advisors. And next, we have Amy Lutz joining us, who has written about severe autism for many platforms, including The Atlantic, Slate, Spectrum, and Psychology Today. So her first book, Each Day I Like It Better, Autism, ECT, and the Treatment of Our Most Impaired Children, was published in 2014. And her second book, We Walk, Life with Severe Autism, came out in 2020. And then last but not least, we have Katie Walton joining us today, who is a professor and clinical psychologist specializing in developmental disabilities at Ohio State University. So she splits her time between research, overseeing clinical programs, and teaching and advising both graduate and undergraduate students. And across these areas, her work focuses primarily on understanding and supporting young autistic children, particularly in the area of social communication development. So she has also worked closely with stakeholder groups to promote greater engagement between researchers and the broader autism community, and also ensure that autistic and other stakeholder perspectives shape her research and clinical work.
Perfect. Thank you so much. Sorry about the tech difficulty. So the first thing that we'd like to do is we should have all of our panelists highlighted here so that you can see them. And first, I'd just like to ask for each of our panelists to give a 1-minute summary of your perspective on ABA as related to autism.
I guess I can go first since I was the first to be introduced. So thank you for the invitation to be here. Like Anna was saying, I am an autistic researcher, haven't experienced ABA myself or delivered it, so have to have some humility there. I love the idea of centering autistic perspectives, not sure though that mine should be prioritized, if there is any sort of conflict there. But that being said, my perspective is that, of course, I'm extremely concerned about all the accounts of harm and trauma experienced as a result of these interventions, and very disappointed to see that large segments of the ABA community have not really been taking those as seriously as they undoubtedly should. At the same time, very cognizant of the diversity of these interventions, of the good work that many people, some of them are here today, are doing to try and make these interventions acceptable and non-harmful and beneficial. And as was said before, that these are interventions that are widely used, and probably in many ways easier to reform them from within rather than trying to reinvent everything from scratch. That is my perspective.
I can go. So experienced ABA basically until I was 21. So I understand how it can be beneficial, but currently the way that it's malpracticed is my concern. And I say malpractice because, just like you stated, it surrounds the medical model of disability, which is to defeat autism. And I feel like historically and currently it's successfully defeating autism, which is successfully defeating our identity and the way that we are framed as inferior, or the way that we are compared to norms that are not our own. And the way that our norms are not considered norms or respected. I feel like the treatment model should probably be changed from treatment to support and accommodation, because we don't necessarily need to be treated, so to speak, but we need to learn how to navigate the world. So that requires learning supports and learning accommodations in order to do that successfully. So I think my concern is the defeat of autism, which is the defeat of our identity.
I guess I'll go next. Hi, everyone. Very happy to be here today. I guess if I can somehow distill it into 1 minute, because I can talk a lot, but my perspective on autism and ABA is that ABA is a tool like anything that's out there, and to be the best possible tool that it can be. You don't want to have something that has jagged edges and that is going to not be as effective as it could be. And so my interest and concern is why is there sometimes a lack of effectiveness with this tool, which I think can be a great thing. And I think I agree with what Joy was saying, that the way it's currently applied in a lot of cases can be damaging, not always, but how do we optimize this tool to ensure the success and happiness of people on the autism spectrum? So that's what I'm looking at and hoping to achieve through reforms to the field, through hopefully having these conversations that we're going to have on this panel today.
Hi, I'm Katie Walton. I'd say my perspective coming at ABA and autism is I'm trained as a clinical psychologist, primarily working with young autistic children. And so certainly I've been trained in those ABA perspectives, and particularly in naturalistic developmental behavioral perspectives, and sort of oversee some clinical services coming from that perspective. And I, as a clinician and a researcher at the same time, have observed that forms of ABA can be extremely helpful and honestly extremely enjoyable for some of the young children we're working with. I've seen kids who just love it when their therapist shows up, and I've seen the opposite of kids whose parents say they run the other direction when their ABA therapist knocks on the door. And then I think we really need to work as a field to better understand what types of ABA approaches or other approaches are helpful for kids. How do we understand both the benefits and the potential harms? And sort of how do we move towards supports for autistic children that are helpful for a broader variety of kids? Because I think what I've seen is a huge disconnect between the strength of recommendations towards ABA from a large proportion of clinical providers and the actual research evidence for the variety of practices as it currently stands, and sort of the lack of nuance sometimes in those discussions or recommendations that I think is really concerning.
Yeah, I think I'll just jump in and just kind of add to what Katie said about the lack of nuance. To me, my whole issue with debates around ABA is that ABA is such a broad toolbox. I find it really tough to kind of understand either the wholesale rejection of ABA or the wholesale promotion of ABA. In my experience as a parent of a severely autistic son and for other kids, I use principles of ABA in all my parenting. I use it in my teaching. When I break down an assignment for my students, that's following the principles of ABA. When I tell my neurotypical son that he can't play his video games until he does his homework, that's following the principles of ABA. So I think it's really important for some specificity in these conversations. Is it discrete trial training that people have found traumatic? Is it what is it about ABA? So I think it's really important that we try to be as specific as possible, because in general, the ideas of operant reinforcement inflect all the ways that all people in our society kind of interact with one another.
I have a lot of thoughts, but what I'll kind of say first is I appreciate all the comments that have already been made, and Joy, when you talked about support and accommodation being sort of a primary focus, or should be a primary focus, it really resonates with me. And the work that we've been doing here with my team, we've really dug into community engagement in a way that I think as a field we've neglected to do really well, or sometimes at all. And so our practice has not really been influenced in a substantive way by the people that we're directly serving. And we're certainly not held accountable to those same people or to groups of those people as we should be within our own practice. So there's been a lot of growth in the field, a lot of challenges that have come along with that growth, particularly in terms of quality control. But that all comes down to this idea that we really need to listen to the communities we're serving and ensure that the goals that we're developing within those services are aligned not only with the social validity at that sort of direct and indirect consumer level, but at the relevant community member level as well. And then I really just want to point out there are a lot of concerns about ABA, and many of them are valid.
Thank you all for sharing your perspectives, and pretty good on the 1 minute, I would say, time frame. That was a great way to start, and I think share sort of where everyone's coming from, or an initial share. And I think what I'm hearing that was consistent with our discussions prior to the panel as well in preparation is just that there's a lot of nuance. So we're going to get into some more structured questions that will hopefully help us parse apart that nuance and share some more specific thoughts. And so our first question that we want to really dive a little bit deeper into is, should ABA be used with autistic individuals? And if so, do you find it useful to distinguish any subpopulations of autistic individuals that should or should not participate in ABA? And this could be based on cognitive or speaking support needs, age, behavior topography, or maybe even forms of ABA.
Should I just go again, keep same order? I don't, like I said, I humble don't want to take up all the speaking time, but I'll, nobody else is going, so I'm going. All right. Yeah, I think this is a really important question. One population would be really young children, preschool age range, where maybe you're coming at this from the perspective of an autistic adult, and you're thinking about monotropism and how people have these very specific ways that they're allocating attention. Maybe you're coming at it from more of a mainstream research perspective and thinking about it in terms of differences in allocation of social attention, whatever. There's still, whatever perspective you're approaching from, going to be a large chunk of the autistic population that are not engaging with the world around them the same way a neurotypical would, not getting all the same learning opportunities as a result of that. And that's where those early interventions come in. And Amy, you were talking earlier about discrete trial training and being specific about things. I really don't think that we need to use those compliance oriented strategies, but in that younger age range, the naturalistic developmental behavior interventions like you were talking about, Katie, I hope that those can be something that we can work on implementing and further reforming in line with what autistic community members want. And actually, I'm second author on a manuscript that's going to be published soon in JAD, hopefully, talking about autistic people's perspectives on some video clips of PRT, one of these naturalistic interventions. And the autistic people thought that the intervention was being done sometimes in a way that was following the child's lead in these short video clips, that it was incorporating the children's natural interests and building interactions around that, and people appreciated that. But at the same time, there were also more critical comments saying that people were withholding reinforcement because the children weren't responding in the way that the adult wanted, and that could be damaging and harmful, and that needed to change, for example. So that's one area. Another big area, of course, being somewhat older individuals who are experiencing meltdowns, their self-injurious behavior, things of that nature, and doing some sort of positive behavior support. I think that's a tool that has a lot of potential and could really be used in a way that is empathetic to autistic people and about trying to find things in autistic people's environments that are causing harm or distress to autistic individuals and getting rid of that. Unfortunately, today it may be often being used more for the convenience of neurotypical people around these individuals. But again, I think that's an area that could be worked on. So definitely various areas, toilet training that, I think could be ones where ABA could, with reform, be very useful. And then, of course, any other area where an individual themselves decides that they will, want to pursue that, and then they're sending to it, that's cool with me. All right. Sorry. Looks like Joy wants to say something, so I'll shut up.
Yeah, go ahead, Joy. Thank you.
I feel like that's a loaded question because I feel like autistic people are humans. And just as Amy said, ABA is the study of human behavior. It's no way that we can remove that from the world. We reinforce, we punish. That's what humans do. So should ABA be used on autistic people? Absolutely, because we're human and the same rules of human behavior applies to us. The only thing that we ask is that it's done respectfully, and meaning that we are considered in terms of our norms, in terms of culture. We're a collection of people that have shared behaviors that are maybe atypical or abnormal, but atypical or abnormal does not mean maladaptive. Those things need to be discerned. Differences need to be discerned from maladaptive. Largely, this is, again, based on the medical model, and the DSM poses these things as problematic. So there's, it's inferred that it needs to be treated because it's not normal. So we don't need assistance with becoming neurotypical appearing or physically doing the things that you do or just acting like we're neurotypical. We need the facilitation of acceptance. And this can also be done with ABA. The less that you treat things and the more that you teach us to support and accommodate, because that's going to generalize society, our differences will become more visible, and that will facilitate a forced inclusion where society, it'll be a reflection of, okay, we're not seeing these things treated, it's more normal. The reason it's abnormal is because it's not seen, because we have to hide who we are. So I think even in asking that question, it's still like a tidbit of like ableism, because it's like, we're humans, why wouldn't it be applied to us? It can work for everybody. Like, it's not, we're not, neither here nor there, we're humans like everybody else. Oh, I'm Joy and I'm done speaking.
Thank you, Joy. And I appreciate you calling that out. And I think that's important feedback for us, right? And for all of us to think about is the ways that our assumptions and our learned biases still permeate just even the way that we ask questions.
I'm happy to jump in a little bit if that's okay. I think that I agree with Joy. And I certainly think that a big thing that we need to be able to talk about within service delivery for anybody is consent, and that needs to be centered throughout all of our practice and the way that we develop our goals and our interventions, regardless of where we are in service, regardless of who we're working with. And there are ways to do that from children very little. And we can start working on and should start working on self-advocacy and self-determination skills right off the bat. And that should go through everything we do. There are those individuals that we certainly work with who engage in dangerous and complex behavior, who need a high level of support. But the focus from a behavior analytics standpoint should really be in that point in teaching skills and thinking about what do we need to develop, what kind of skill sets do we need to develop for this person, so that way those complex and dangerous behaviors are no longer required. And then in terms of how we can engage in ABA beyond those things, I mean, there's certainly a number of behavior analysts that work in academic instruction and supporting skill development unrelated to complex and dangerous behavior or compliance driven or camouflaging driven practices as well. So I think that there are certainly opportunities to apply the science of behavior analysis across a broad spectrum of people. including those who are autistic.
And I agree with everything that's been said. I think one thing that I want to add is there's obviously nuance here. And I think the real question is when and how should ABA be used and what types of ABA are we talking about? I think that people tend to jump to discrete trial when they think about early intensive behavioral intervention. And my inclination would be, why should we take something out of context to teach it if we haven't tried teaching it in context first, in ways that are more naturalistic and more close to the environment that child is in, and hopefully more enjoyable for the person that's learning it. And in most cases, if we can find a way to teach it in a fun, engaged way in that environment, that's closer to how, as Joy was highlighting, all people learn, right? We all learn as a part of our environment, and behavioral reinforcement principles are part of how humans learn from their environment. But I also think, as Pablo was highlighting, there's a time and a place for identifying a behavior that might be a real problem for a person, whether it be an older individual who can say for themselves, this is a thing that I really want to be able to stop doing, and I'm having trouble stopping doing it. So I want to do something more structured, and I am willing to engage with you about how can we make that happen. Or it may be a young child where direct consent from that child may be difficult to get, but that we can see that this is something that is distressing or dangerous or problematic. And that if we can be able to enhance that child's overall experience in the world by doing something a little bit more structured for hopefully a short period of time, that sort of working with the family members, working with the person, getting input from autistic people about the acceptability of these things, as Patrick referred to, it may be really beneficial to do some of these more structured things. But I think it can't be just a blanket of should we or shouldn't we use ABA, or even should we or shouldn't we use discrete trial or NDBI or any of these specific techniques, because I think it really probably depends in many cases on the time and the place. Maybe not in all cases. There might be certain types of things that we say this is always unacceptable. But I think in most cases, it really depends on the time and the place and the situation and the people involved.
So I am not a clinician, and I do not have broad experience with the application of ABA across the autism spectrum, but I can just speak as my lived experience as the parent of a severely autistic son, and very active in the National Council on Severe Autism. So I have known many families who have are in a similar situation. I will just say that ABA techniques have been absolutely invaluable in teaching some really fundamental kind of life skills to my son. We have kind of lists that are just posted in our shower next to the sink, the steps of brushing your teeth, taking a shower, just trying to teach him some more independence. We've been working on trying to teach him just to stop at the curb when he crosses the street. There are real safety issues that we're using principles of ABA to treat. I know another family where their daughter learned to understand, first this, then that, using some ABA instruction. So she was able to understand what was very frustrating to her before, that, first you put on your shoes and then you go outside. This idea that just some really very fundamental skills that are not meant to normalize these individuals. They're just meant to give them more independence and agency in the world. So yes, I think that certainly in the population that I work with, ABA has been and in all different manifestations has been really helpful.
Thank you, Amy. Joy, go ahead.
I feel like we're keeping it real cute. And I want to get to what people need to also realize is we're not talking about just brushing teeth, bathing. We're talking about other things that comprehensively have to do with identity. And a lot of times, if you would have asked me certain things when I was 12, there's certain things that I did want to be targeted because I had that innate ableism because my parents, not intentionally, but had that expectation of me presenting as my neurotypical peers or achieving some of the same things. So of course, I'm going to say as a 12-year-old that I want to do those things because I hadn't yet reached the point that I've reached now and realized that who I am authentically is valuable. And the happiest I've ever been in my life is being able to be free and be who I am and not, you know, really try to model myself after neurotypical people. And often with young children, I was non-vocal until I was 12. So until I was 12, my parents was the default consumer. And the practical application of ABA always looks like, okay, in all this research, even Bayer since 1978 has been saying social invalidity will be a thing. He predicted this would happen because consumers would be upset. But the problem is people always make the parent the default consumers and don't really measure us in terms of qualitative literature to get a baseline of what our norms are and what we want, you know? So that is like happening right now, what he talked about. And that's because we, you know, like all of this is coming into fruition because this is true, you know. I kind of lost my train of thought because I'm just so like all over the place. But I just kind of really think that people really need to think about how we're not talking about just brushing teeth. We're not talking about just bathing. We're talking about a lot of other things that happen in ABA that contrives who we are. People say, like Katie said, you have kids that are happy to see it. Yeah, I was real happy to see it, but that was contrived descent. It's no different than if somebody would have came into the park and watched my behaviors and saw what I wanted in terms of reinforcement and I left with them. You would have said, oh, she left willingly, but did I really? Because they watched what I wanted to do. They used those reinforcers to contrive my compliance, to contrive my participation. Now I have a problem with discernment, especially since I'm in the field. I don't trust nobody in the field because to me it's so unauthentic what occurs in pairing. It's such a superficial experience in terms of reinforcement and socialization. I don't know who's really my friend and who's not. Oftentimes I'll be working with other BCBAs and I kind of feel like, are you pairing with me? You may say it's overgeneralization, but I say it's generalization because I experience this across settings, across people. This is a culture of like you giving me this superficial socialization, this superficial reinforcement. It was not beneficial to me. It contributed to my vulnerability because I started looking for that in other people. I was disappointed, confused, because this is not what I experienced. But in ABA, I was happy as hell because I was being reinforced all the time of what I wanted. But was it truly beneficial when it came to real life? No. So then you end up with this angry adult who realized, okay, yeah, I had some fun times, but what did that really look like in terms of how it shaped my behavior? And what I really learned in terms of socialization and what I experienced in ABA. It was really superficial, really not realistic, really not anything I had to apply. I'm having to go to therapy to undo therapy, you know? So you have to really think about those things and how it really looks, because I'm working in the field and I could tell you, I probably cry once a week because I cannot trust my discernment because of how deeply that shaped. I think somebody smiles and is happy. I've learned that that's not of what a friend is. And then that also translated to me in like high school and school. Like you often see autistic people have problems not being able to discern who's really their friends and who's making fun of them. That's because that's shaped in ABA. You just happy, smile, give us what we want. We think you're your friend. I think these therapeutic alliances and the basis of like pairing and all of this stuff needs to be reframed, reshaped, really looked at how we are considered sometimes like, no offense, Amy, but it hurts to hear her say like severe autism. Like, what does that mean? Like I was, my IQ was deemed to be under 70. I didn't get it. I was in self-contained classes my whole life. I didn't get a GED until I was 26 because I was placed in these categories. And I think sometimes those categories alone just kind of eliminate what you can, because people automatically assume that you're in this category, you can never move from it. And I feel crazy now that I teach college and I couldn't even get a high school diploma because I was non-speaking, because I was not neurotypical behaving, because I had extreme behaviors, aggression. And now just realizing just if I was handled differently, because I'm gonna say handled because I feel like I had handlers, it would have looked a lot different, you know? I kind of ranted, my bad.
Thank you for, no, Joy, I think it's, we know that this will be somewhat long-winded, right? Or we know that the passions run high and that we are sharing our own views that maybe aren't other people's views. And like, that's the point, right? Is that we're all sharing our own perspectives. Katie, please go ahead.
Hey, so Joy, no, I really appreciate that perspective. And I think it's really makes me think for you to say, you know, feeling like the child is happy to see you and that they feel like they seem to be enjoying themselves from any indication may or may not be an indication that this is good for them. And I think that's really worth thinking about, particularly the way we know that reinforcement works in theory. We know, as you point out, behavioral principles are a thing. They work. This is a way that people learn, but then is that learning useful or not? And I think this is something that I've thought, had a lot of discussions with the NDBI framework with my colleagues about, and that I think oftentimes that our less ABA based strategies that are part of that are engagement strategies that are, BCBAs call it pairing. Frankly, I hate that term. I think that if you are actually going to genuinely try to build a relationship with somebody, then genuinely try to build a relationship with them that is based upon mutual appreciation of one another, not just based upon I'm trying to make myself reinforcing. And so I think that has to be the baseline of how we treat children, even if we are doing therapy with them. And I think that genuinely trying to understand and connect with a child about the things that they like and the ways that they like to play and finding that enjoyment with them. And I remember talking to a parent where we had encouraged them to do some NDBI strategies, like imitating what their child is doing, getting on their level, trying things they were doing. And, the parent said to me, they're like, I never sat down and dropped little pieces of paper on my face before, but I'll be honest, it looks kind of cool. I can see why he likes this. And I feel like that was a genuine moment of this is probably a way these people are, the parent and child are connecting, but it's also a moment that parent is having a relationship moment in a real empathic space with their child. And so I think those things are really powerful, but I think it's a really good thing to keep in mind that can get confounded with just too much reinforcement. And I think the challenge is how we tell the difference there. Because I do think that there's a little bit of danger, because I do some therapy with, adolescents and adults. I've done some therapy with adult clients in the past, and you hear from people, well, you're my therapist, you're paid to be nice to me, so obviously you don't actually really care about me. And I honestly, it's a different relationship between a therapist and a client, but I can say that I have clients that I had 15 years ago for 6 months, and I still think about them really fondly. And it's a different type of relationship, but I had genuine affection and regard for a lot of my clients. And I like to think that I have genuine affection and regard for the vast majority of the kids that I work with. And so I think that it's possible to live in both of those spaces, to be working from those principles and also be forming a genuine relationship. But I agree with you that doesn't mean that's always what's happening. And so I think we have to be careful in that space.
That's a great addition of that nuance. Go ahead, Patrick.
Yeah, I really appreciate all of these comments, Joy, and thank you for your courage and forthrightness in saying that. And, to pick up on one of the things you were saying earlier, you're talking about how, in our society, it is very difficult to, sort of stand up and, take off the mask, that there is so much pressure pervasively throughout our society, that maybe somebody would be would think that this is what they want to do, to have a more normalization oriented goal, and perhaps that's not actually the right decision for them to be making, but they're facing so much pressure. So one of the things that well, you yourself, the fact that you're in this field and other autistic professionals are in this field, I really hope that there will be a cultural shift there, as that can change what people are hearing from professionals around them. I hope as well that there will be more of a shift towards having autistic consultants and community partners that are really heavily engaged with in these interventions. It's interesting in another study that not ABA specific, but just about autistic perspectives on intervention generally. We had asked autistic people and non-autistic people, like parents and so on, about their perspectives on who should be in charge of intervention, and I was interested to see where the autistic parents of autistic children would fall. Would they think that, really parents should be in charge, or, autistic people should be very heavily involved as consultants, the individuals themselves, of course, to the extent that they're developmentally ready. And, the autistic parents were somewhat in the middle, but they seem to be more on the side of their fellow autistics than their fellow parents, as it were, which I found very interesting. Anywho, I don't know where I'm going with this, other than, I guess, just to say that I think having autistic people, very meaningfully involved in all these things in order to bring about that cultural shift to empower young autistic people to have that pride in their autistic identities.
Yeah, that inclusion I think that you're speaking to is an important piece to add in. Let's hear from Amy, and then we're going to shift to our next question.
Well, thank you. I was trying to listen and absorb everything. It helps me to get a feel for where everybody's coming from before I get my own answer out there. So thanks for saving me till the end here. But I agree with so many things that have already been said. I was thinking about Patrick and Joy were talking about the masking and everything, and I was also thinking about, for me, I always consider myself a failed masker. I tried to imitate my peers and do what they were doing, but it was never right when I was doing it. I couldn't hide the fact that I was autistic, at all. And so I remember the reactions of my authentic emotions were something that were always negatively reacted to, right, by the people around me. And I toured a school recently for children on the spectrum, and I saw one of the techs doing I don't know if it was discrete trial exactly, but they had a child there they were working with, and the child was crying, and the tech was still doing the whatever they're like. There's a crying child in front of you. I know you have your log sheet, you have whatever it is you're supposed to be accomplishing at this moment, but a child is crying, and why are you not responding to it? You know what I mean? It just struck me so deeply. And I don't, again, maybe there was some context I'm missing that I don't know about, but all I know is that I see a non-speaking child, it seemed, from what I could tell, crying and still being instructed to do whatever it is the tech is saying to do. And I feel like, that's what we run up against sometimes, is that it's a funny thing that one of the diagnostic criteria with autism is restricted and repetitive behavior, because ABA is restricted and repetitive. By its definition, right? I mean, so it's like, pot, kettle, FYI, you're black, you know what I'm saying? It's just, but within that, I mean, I feel like there's such great possibilities, but because of the kind of the origins and the way that things have shaken out, we're missing so many great opportunities, right? And like you were saying, Katie, I always knew as a kid when someone was looking at me because they were paid to look at me versus because they actually care. That's what I was getting at with the child, crying like that. Like, are you looking at this kid because you have a job, you got to do it because you care? If you care, wouldn't you notice that there was a crying child, right? So I think just all too often, and the original question was about, should ABA be used with autistic individuals or not? And again, like Joy said, it's a complex and loaded question. It's impossible to answer that without looking at the individual situation and the individual person. But by asking it that way, it again turns autistic people into this monolith, which we're not. We're all so you can't just generically say yes or no. It shouldn't be used with folks on the spectrum. And I mean, that's, again, that gets to the heart of this nuance that we're trying to reach in the very limited time we have on today's panel. So that's just what I wanted to say.
Thank you, Amy. And there are, right, so many voices, right, and so many perspectives that I think we're all listening to and hopefully learning from each other as well. So I think we're going to switch to maybe combining some of those next two questions together in the interest of time. And I think that the next question that I would like to move us into is thinking about the behaviors that we would want to be targeting or not targeting, but also incorporating then the safeguards and the considerations for the ethical research and clinical practice for these behaviors. So great understanding and acknowledging that, as many of you said, that there are specific behaviors and there are specific approaches or times or ways that ABA or ABA principles can be delivered. What are those times? And then the ethical considerations and safeguards that we need to maintain safety.
If nobody other than me talks in the next 10 seconds, I'm going to talk.
Just talk. We don't have 10 seconds. Just go.
Okay, fine. All right. Yeah, I feel like this panel has already done a great job talking about some of the issues around using targets, but a point about considerations and safeguards, out in practice, that is so important. Like, we could talk endlessly about how we want this to be done in like an ideal world, but it really is kind of like a wild west out there with all of these behavior techs, as you were saying, Amy, who have like zero training, BCBAs who are trained in a deficit model, a lack of regulatory oversight, all these for-profit companies going around. So how do we make these things have an impact in the real world? That's the question that I'm really wondering about. Like, I feel like we need to do a lot more to ensure that people are being trained in a way that acknowledges the harms that people are reporting as a result of ABA, that takes that very seriously, that emphasizes the need for social validity in a real way, and that prepares people with the information they need to know. And then there needs to be, some sort of oversight to actually ensure that that's happening in the community. And that's going to be really hard with the model that we have, which seems to be aimed more at reaching the maximum number of people possible with some intervention, just so that they can get some intervention, which is important. We don't want to lose that capacity, that scalability. We don't want to have a bunch of people on wait lists, but we also need to make sure that they're getting a good and ethical product, right?
Thanks, Patrick. Go ahead, Joy.
It's just that's again very individualized, but a lot of things that are currently targeted for reduction should be shifted to target for management. For example, like the common ones like self-stimulatory behavior, unless it's harmful, it don't need to be targeted for reduction. It can be targeted for management. So management to me means you learn how to advocate, the parents receive parent training to learn how to accommodate that child. So I think some of the things don't necessarily not need to be targeted, because you can't ignore that somebody engages in behaviors that, especially like I'm Black. If I stim in public, it's going to be a problem. So I need to be taught how I'm going to be perceived. And I need to know how to advocate for myself as an autistic person who is also engaging in, like in atypical behaviors while living in my skin as well. Not saying teach me to stay still, but teach me if I'm approached, how to let people know what's going on and be comfortable with that. So I think that a lot of times when people say don't target it, they think saying, like completely ignore it. I don't think we're saying ignore things. We're saying teach autistic people how to maneuver the world. Like, you still have to target these things, like eye contact. I don't need to look at you, but I could say, hey, Hannah, I'm not looking at you, but I'm paying attention. The goal is responding, not making eye contact, because making eye contact is a prerequisite to masking, because you're teaching me how to please other people opposed to looking out for myself when I'm overstimulated. So I think a lot of these things just need to be looked at from a different lens, saying, yes, they can be targeted, but in a manner that helps that autistic person maneuver a world that's not necessarily made for them, but allows them to keep their identity intact, keep what they need intact. I stim because it's needed for me to regulate, not just sensory-wise, but emotional. I stim when I'm happy. So if you stifle my stimming, you stifle my happiness, because it's how I physically exhibit my happiness. So these things need to be looked at in terms of who we are and the function of it. And like I said, people, if somebody approaches me in Starbucks so I don't get tased, I need to say, hey, I'm just, like be able to explain it, not just think that I'm not going to be perceived differently in our current society. But I want to say, over time, the more these things are not treated, the more we will shape the acceptance of it. And it won't be that I'll encounter those type of things in public. You know what I'm saying? So that's also a thing.
So I hear you saying not even just like the behaviors themselves, right, but how we're thinking about even supporting those behaviors is,
and of course,
or shifting or not shifting.
And I think it goes unsaid saying like, like aggression, harmful behaviors. Of course, those things need to be like targeted. However, we do need to think about when people sometimes targeted stimming that is harmful, they don't try to replace it either. They just try to reduce it. You still need to think about that autistic person is perceiving that sensory input differently. So they're going to need some type of replacement behavior. So I think people need to really make sure they focus on also giving them some type of behavior that's not so like generic, like a spinning toy is not going to help me from banging my head. I'm going to need some type of other creative, more the same type of match sensory input that's done in a way that's not harmful. And that you need to put as much attention as that as you, because they're going to be dysregulated if you don't. So it needs to be comprehensively studied. Like, yes, this is harmful. We don't want you to do this. However, we're going to give you a yoga ball and teach you how to advocate for yourself when you need to go take a break and bounce on that yoga ball so you get that same vestibular and proprioceptive input that you're trying to get when you banging your head. You get what I'm saying?
Yeah, absolutely. And I think your experience also, right, speaks to a lot of understanding what would be a reasonable replacement and what is just not even close. But I do want to shift. Dr. Lutz, you had your hand up. Is there something you wanted to say?
Yeah, and I'm kind of struggling to articulate it clearly, so I apologize if this sounds like a mess, but I'm honestly having a lot of trouble reconciling what I'm hearing about identity and masking and normalization to our experience and experience of all the families that we work with. I can tell you, you ask what severe is, it has nothing to do with any of that. And none of the families that I work with or what my son is doing has anything to do with eye contact or stimming or normalization. There's nothing about normalization. These are kind of life and death behaviors and profound crises that these families are living with. So yeah, I talked about brushing teeth because that was like a fun, light thing to show one application of ABA. I could also tell you how my son is giving himself cauliflower ear by punching himself on the side of the head when he gets agitated, and how we're really concerned about finding a replacement behavior so he doesn't lose the hearing in that ear. He spent a year when he was 9 at Kennedy Krieger just because he was so aggressive, and finding the right combination of a medical framework, medical interventions and behavioral interventions that allowed him to go out in the community, go back to school and live at home where he still lives, even though he's 23. I mean, these are very impaired individuals, who really need ABA to help them learn just a little bit of independence. I mean, my son's always going to require round-the-clock supervision. He's never going to go to college. He's never going to graduate from high school. He's, and so how can I help him be able to master some life skills and achieve some agency in the world? One of my friends and her son died in a fire because her severely autistic son wouldn't leave and she couldn't leave him. So when I hear people talking about, so excuse me, I'm getting a little upset, but just we are in the severe autism community, we're not interested in masking. We're not trying to make our kids normal. The idea of Jonah never makes eye contact, it's fine. That's not what we're working on. We're working on skills that are so much more basic and have to do with safety, have to do with communication, have to do with maximizing their quality of life. So it's just, I almost feel this is like a non-productive conversation because we are in two different universes.
I don't think so, though.
Hang on? I think that Amy Gravino had her hand up before.
I'm sorry, Amy.
Were you looking?
Oh no, it's okay. I mean, if you guys want to continue that, I would say something completely different. It's if Joy wants to go ahead, that's okay.
No, I was just gonna say, I understand. I don't want Amy to think I don't understand. I don't talk about my child all the time because I feel like she can talk about herself. She's 28. She's not neurotypical passing. She's eye gouged to the point where I've had to have her retinas replaced. So she will probably be classified as severe. However, I have a grandchild that's also autistic too. She has 3 children. She's married. Her husband's autistic. They're both what people would consider not neurotypical passing, and not what people always ask me, how is she married? Like they don't expect her to have sex. I think there's just a different perspective. I didn't expect, or I wasn't so surprised when I had an autistic child that engaged in these things. And I think if you saw me years ago, you would see something very different. I was labeled as aggressive. I used to be labeled as an extreme masturbating child. It's just, I was in self-contained classes my whole time. I was institutionalized 63 different times in my life. I grew up around what was considered severe, so I understand. But what I'm saying is, when I hear that, it hurts me because I'm part of the population comprehensively. But I'm not saying that I don't understand that there are people that present different than me, that have different challenges than I have, because I have a child and I have a grandchild myself. So I don't think that we have to separate like who we are. I think we can all like talk about our community comprehensively and care about no matter where you are, you know, like in terms of what you need in terms of support.
Okay, I want to give some space for Amy, if you wanted to say something, and then Patrick raised his hand as well.
Sure. Well, all I was going to say is, again, as was mentioned in the intro, my area of focus tends to be, you know, sexuality and stuff. And so thinking about a lot of the behaviors, you know, almost all the time when BCBAs are brought in with anything that has to do with sexual behavior, it's to stop something. And there's not really any teaching going on of you know, differential reinforcement of an alternative behavior or another behavior. You know, there's a lot of stigma around autistic sexuality, a huge amount of stigma. And so we forget that you can't just say, don't masturbate. It's like, well, you know, the cat's out of the bag, man. That's too reinforcing. That's not, you're not putting the peanut brittle back in the canister. Like it's done. So we all right, I'm getting emotional too. This whole thing is a tough conversation to have, but it's a great conversation. I'm glad we're talking about all this stuff. But essentially, you know, this kind of gets to the heart of what we talk about with the over reliance on compliance at times, and that, you know, saying no is something that's super important as well. That's gets down to safety. It's not just about, I know some folks will say to me, well, you know, that has nothing to do like with my child, you know, they're not going to have, but saying no is just as important as saying yes, and being able to keep someone safe in any situation, whether it's a relationship situation or just with a friend or with someone who isn't a person who says that they're an authority. Oh, come with me, I'm in charge. You don't want a child to comply with that with some stranger that they don't know who could harm them, right? So I think that's, you know, that's just something to bear in mind as well when we're talking about, we want to be teaching stuff just as much as we want to be stopping behaviors. We always have to be, because to me, if your behavior analysis isn't socially valid, then what is the purpose? You know what I mean? This has to be stuff that people will take with them for the rest of their lives. Safety stuff as well, all the way from basics to the complexities we're talking about with sexuality and relationships. All of it, I think, is, you know, socially valid. I think that's what, you know, should really be focused on.
Thank you. I'm glad we got to hear from you as well. And Patrick, did you want to add to that?
Yeah, I was just going to say, hopefully, well, we'll see how this flies. So, you know, all of these, you know, controversies around like severe autism and things, there are, you know, genuine and important issues there. But you know, what I'm hearing from you, Amy, from Allison Singer and others, is really that you do want to, you know, ensure that your children are thriving or having good quality of life, that you know, and those are things I think are, you know, really consistent with what the neurodiversity movement is looking for as well, and what you're saying, that you're not aiming to normalize, to just, you know, teach useful adaptive skills that will get to the point where people can be more independent and have, you know, that better quality of life. Again, very consistent with the neurodiversity movement. So I feel like a lot of the time, especially when we get on social media, and given that we're coming at things with different perspectives and positionalities and different terminology for talking about things, and, you know, we often end up talking across purposes, and you know, really emphasizing areas where we do disagree, and those are important disagreements. But I feel like there is still a lot that we have in common and that we can agree on, hopefully.
And I think one of the hopes that we had, as you know, as we spoke before the panel and for the panel now, is that we do come together in a shared space, right? That they share all of these different views, and acknowledging that there are different views, but that hopefully that, you know, I think this conversation so far, I've been learning a lot, and I hope others have as well. And so we do have a few minutes left to try to get in one more question before we would switch to our breakout group. So I think that unless there's other very pressing thoughts, I do want to also take some time to talk about the intersectionality that Joy, you brought up, and that I think is really important to consider clinically as we're making recommendations or as we're delivering services. And so, ABA intersects with many minority identities, autistic individuals from minority races, ethnicities, socioeconomic status, gender, sexuality, as Amy was mentioning. So how have you seen, or what is your experience with this intersectionality, how ABA applies, not just to autistic people, but to autistic people in these maybe multiply marginalized groups?
Amy, you go first this time.
Okay, all right, okay. I will. I didn't want to step on anybody's toes. Well, like I was saying, from my work, from the things I've seen, I still have intersection with people on the spectrum who are also identify as LGBTQ, who are facing kind of a double stigma in a lot of ways, who not only have to cope with being on the spectrum and needing support in that regard, but also may need support, but because they identify as LGBTQ. And kind of if we do have conversations around sexuality and autism, it's often from a heteronormative perspective. That's again due to that discomfort around these areas. And then when you think about the field of ABA and kind of there's an overlap in the history with Ivar Lovaas was a pioneer of conversion therapy, as I understand it. I think that gets a little muddled when we talk about ABA sometimes, but it's a concern that people sometimes say is their worry about that it's that ABA could be seen as autistic conversion therapy. I don't necessarily agree with that. I'm just saying this is a concern that's often stated. But in terms of folks who are LGBTQ, yeah, it is I think it adds a double layer of difficulty. As a woman, being a woman on the spectrum, that's been had its own share of challenges, certainly. I've been in many environments where I am grossly outnumbered by men on the spectrum, and I'm either ignored or hit on, which is like, I'm not here for either of these things. I just need help, and it's like, yes, I have breasts, but that's not all of who I am. You know what I mean? And they're great. Don't get me wrong. It took years to grow, but hey, I'm a person too, attached to those things. And I'm not, I'm being treated just, there's so many women I know who are misdiagnosed, who don't get a correct diagnosis of autism because they are female, because the diagnostic criteria were developed observing boys. And so any form of autism that doesn't present in that specific way is not seen as real quote autism. And it just causes so much unnecessary suffering, I feel like, for autistic women who, again, there are starting to be autistic women only spaces like Felicity House, which is in New York, which is really awesome. But still, it's difficult, when number one, most supports and services are geared toward parents of kids on the spectrum. And then the spaces that are for autistic adults are kind of often filled with like a lot of men, and then like, don't even get me started on social media and how rife with misogyny that tends to be within the community. I have faced that as well from men on the spectrum. I've been viciously attacked, in a variety of ways. So yeah, it's definitely, we don't have enough time to get into all that, but that's just some of what I've, encountered in my experience.
Thank you for sharing your experience. Joy, go ahead.
I feel the same way. It's not enough time. However, I agree with Amy. The assessments are key in part of this because the assessments measure a lot of things. The assessments are ableist, racist. The normatives they use are, like these American norms. So if you have people that are here that are immigrants, a lot of that doesn't apply to them, so it's so many things. And being a Black woman, luckily, I had the privilege of raising because my biological daughter, the one that I'm talking about, the 28-year-old, she's Black. I went to Germany because I didn't want her to be raised in this education system here. So I literally intentionally went to Germany and raised her in Germany. Well, it was the Waldorf theory. So she would be comprehensively seen as a human being versus just her diagnosis. And that was my remedy. And then I said I was going to come back, and try to do this work when she was an adult because I didn't want to risk her being here. But being a Black autistic woman, I will see you often, my autism is lost in my identity because people view me as aggressive, direct, or socially inappropriate, but that's what Black people are anyway to people, so I feel like a lot of times people don't even consider, my neurodivergence because they're like, she's real direct, she's aggressive, so, and in this field, as only 3% of us are Black. So I never feel like I'm amongst peers, but as a clinical director, I can tell you all of my employees are all white women. And I work in Baltimore, which is 86% Black. And there's a big problem with cultural humility. People don't know how to discern challenges from maladaptive behavior as it pertains to like social, economic, and cultural differences, you know? So I sometimes find myself like not understanding how they don't understand. So we need more people of color, more, not just Black people, because like I have a large population of El Salvadorian clients too. I can't find a Spanish BA to save my life, you know? So like, I just wish there was a way for us to usher more just people who are just not white to help kind of, you know, because we need to be each other's peers. There are times where I need to lean on y'all, you know what I'm saying? But y'all got to lean on us too. We can all learn from each other, you know, and you, it just will be really helpful. It was a lot more diverse in the field. The type of calls that I get is like calls that I should not be getting. You know, like people just don't know how to recognize cultural differences, and they think there's some type of mental illness there because they're doing something that Black people do culturally. And I'm like, girl, that is not a mental illness. Like, you know, so it's rough.
Yeah, and you know, our field is so white dominated in like autism generally that you know, the relatively small number of autistic people of color I know are constantly getting run off their feet with requests to, you know, do this, do that, and you know, limited spoons, right? So yes, you know, having those that leadership from autistic and non-autistic people from those communities is so important, yes, but also there needs to be appropriate compensation and really trying to go out and not just look for the same people all the time who are so overwhelmed by it. So much there that needs to happen for our field to get to a point that it can be delivered in a way that is culturally responsive and sensitive and humble.
I think that's a great point, Patrick. And as you're saying that, I'm thinking about all the systemic barriers that make it difficult for an autistic person to excel, right? As Joy has also mentioned in the education system. And then also all of those barriers that we know for people of color and for minorities to excel in these systems as well, right? And so the combination of those two things together, right? If you're Black, you might, some people might make it through into higher education or might make it into leadership positions. And if you're autistic, some of us might make it, but the combination of those two barriers combined, you know, we're as you're describing that there's just really low rates of autistic people of color in higher education or in leadership positions. Other thoughts or shares on this question, and then we'll do a final wrap up.
Just that the system is not really set up for any of us to be successful. You know, if you're someone on the spectrum, whether you have high support needs, whether you have more minimal support needs, none of us are getting the supports that we really need when it comes down to what the organization, the governments, the things that are in place are not helping us. But then when you add in, if someone is female, if someone is Black, that's another strike, another barrier that is preventing that person from getting those services. So I agree with what was said before, that if we listen to each other, we you know, could do so much to help each other, because as it is, the divisions that kind of foment, we end up missing the piece that we're all not getting what we need. That's the thing. That's so and then these barriers, again, like I said, they add to that more so, but it's definitely, I think we have much more kind of that unites us than that divides us at the end of the day. That could also be because I'm a hopeless optimist, but that's you know, that's my perspective. So
We need the optimism. Any thoughts from any of the other panelists? Okay, well then I think we'll move into wrapping up. As much as obviously this conversation could go on, I think for at least another 30 minutes to hour, but we're sensitive to the time. And we have a few more minutes until our break. And then we hope that everyone will return to continue their discussion in these breakout groups. So we would just love to wrap up if each of our panelists would be comfortable sharing, like just in a minute or so, the one most important thing that we should remember when we're counseling families and making recommendations for supports or in our own clinical practices, based on the topic that we've been talking about ABA.
When and where will the recording be available?
We'll send out that information after the panel. There's a live transcript also that Kara linked in the chat, and she can send it again. Go
No, I
ahead,
think
Amy.
Oh, sorry. I was just going to say, I think the one thing I would say, and I say this all the time, for BCBAs, but is that the words you write carry so much weight. They are extremely, heavy words. Like if your words had a physical manifestation, they'd be an elephant, I think is the best way that I could put it. And the things you write have the power and capacity to influence how other people are going to see the autistic individuals you serve. And they have the power and capacity to influence how the autistic individuals you serve will see themselves. I have assessments that were written about me that my mother still kept all these years later, saying, Amy is unable to understand the intricacies of interpersonal relationships. Amy does not have any empathy. And things were written about my physical appearance and my weight and my body. I was 9 years old when these things were written. Okay. I was 9, 10 years old. And my sense of self-worth was in the toilet as it was because of the bullying I was experiencing. But to think that the adults around me were seeing me the way they were is a devastating thing to think about. Because it's not just that they were seeing me that way, it's that they were writing these things down in black and white and essentially saying what my future was going to be or not going to be. Right, saying that that they said the same things, that I wasn't going to finish high school, I wasn't going to go to college, I wasn't going to do, anything really. And there's so many parents who are anxious, who are looking for supports for their child, who are looking to keep their child safe at the end of the day. And so the things you write, they make this determination that you may not see, because at the end of the day, you put your file back in the cabinet, you close it, and you go home. But this is our lives, right? We keep being autistic after you've gone home from work for the day. And we keep being autistic in this world after we've left your building, your school, whatever it may be. So those things stay with us. The thing, they don't call them formative years for no reason, right? The things that were said when I was that age have stayed with me in one form or another. Obviously, my self-esteem is in a much better place now, but the fact that that's part of my foundation is always going to dictate on some level who I've become. Not fully, but it's that peace. It's that peace that never fully goes away. So just for folks to bear in mind that things you write really do matter. And they just need to be taken into serious consideration, because they're also going to say to people, can autistic individuals grow and change? Maybe by your words, you're indicating, no, this is where someone is, this is where they'll always be. But we are human beings. We have the capacity to grow and change, just like others do. So give us that chance, to grow like you would anybody else. And don't condemn us essentially from the start. So
Yeah, that is,
Oh, I'm sorry.
No, you go ahead. I went ahead a lot earlier.
No, I just wanted to piggyback off Amy. I just kind of want to reiterate the same thing she says, because I've been recently going through my treatment plans, and I want y'all to also think about, if you buying what you selling, think about that we can be your peers and we can be here. Because a lot of the people that I'm seeing now, some of the people that treated me are still in the field. And me showing up, they did not expect it. I was not expected. I don't even have a high school diploma, so I wasn't expected to go to college. But they never expected that with proper accommodations, it might have took me longer. It might have, I'm 46. I'm just now, like getting in the field. But I'm here. But because you wrote those things about me, you never expected it. Like, do you want us coming to you face to face and wanting answers for why you put these certain things in our treatment plans? Like, they used to say that my antecedent for masturbation was Big Bird. And really it was self-stimulatory behavior that involved genitalia. And I was excited because I saw Big Bird. But the way they phrased that made me seem like a sexual deviant my entire life. And so, like Amy said, I internalized that. And I felt like I was this sexual deviant. People, like, she's gross. I thought I was attracted to birds for I don't know how long. like, because that was shaped into me. You know, like these are things that like that people shape. People in these assessments, when we're saying, doing personal questions, and you're telling people, when we talk about the non-binary or LGBTQIA community, you teaching people what gender they are when they 3. You don't need to teach them what gender they are. Wait till they tell you. Like, those are things that we really need to think about, that I stopped putting gender in my treatment plans months ago. Insurance ain't said nothing. So all of the people that say like insurance is going to do that, no, insurance just needs to know the behavioral facts about your child, because the gender has nothing to do the way they behave and the way they behave. You know, so stop shaping these things and telling us who we are in these treatment plans, because going back and reading these things, especially like I was considered so aggressive, so like sexualized. I felt like I was just this horrible person that would never have any type of future. You know, I was deemed to be like institutionalized, you know? So think about that. Like, I really agree with Amy. Y'all think about that. You want us coming for you, because me and Amy will come for you.
Yeah, if I had a dollar for like every autistic person I've met who is doing fine but was predicted to be doomed in life when they were 2 or 3 years old, I would be rich. Of course, there are people who are going to have very high support needs, but you know, we just don't know yet at that age, and people still feel the need to predict for some reason. Not that that's remotely useful. The other thing, you know, there's work being done on these family navigator programs, connecting people with you know, other non-autistic parents, which is great. And you know, I think it would be wonderful if we did more to connect families with autistic people, you know, from across the diversity of our autistic constellation, because yeah, you just don't know when somebody is 2 or 3 years old what they're going to turn out to be, and that's terrifying for these parents to get this diagnosis and to you know, imagine the worst possible things. But you know, connecting with people and seeing the full diversity of the autistic constellation and what's possible, and hearing, you know, autistic people's perspectives on intervention, I think it's something that's important and not being done a lot.
I think that obviously I can speak more from the, you know, what should we do as a clinician? And I know I'm speaking to a lot of clinicians here. And I think my biggest advice would be that we all need to be a bit more humble and admit how little we know about what is actually the right thing for any given child who shows up at our office. And that I think making blanket recommendations for any particular treatment or any particular service, we don't know. And it doesn't mean we can't, like, we have to make some recommendation though, right? And it depends on the what we're talking about, how strong we think we can make those recommendations. But I think sometimes we have to have the humility to trust the people we're talking to with the truth, which is, here are some things that might be helpful. We don't know very much about who they're helpful for. I don't know for sure that it'll be helpful for your child. I also don't know for sure if there are parts of this that could be harmful for your child. And that's something that you have to be really careful as your child's advocate and their parent to be watching out for. And there might be things that are helpful and there might be things that are harmful. And you have to work in collaboration with your clinicians to make those determinations. Because I think that the longer I'm in this field, the more I realize that I don't know what to write to be the most honest with parents and with families, and that it's oftentimes needs to be a much longer conversation than a list of recommendations in that assessment report. And I think we need more of that. And I don't know how we make that work in service systems. But I think that would be my piece of advice, is realize that we know less than we like to think that we know, and that maybe sometimes we need to be honest with the people that we're working with about what we don't know, as well as what we think it might be a good option.
Just say real quickly, as a clinician who has taught this over the last several years, by a number of autistic people. And as a father of 2 neurodivergent children, one of whom has autism, I am a staunch believer that everything we do in practice, and I'm going to repeat myself, but everything we do in practice has to be consent-based. And there are ways to do that, no matter how young the child is, and no matter how much support and extra resources they need. There's always a way to do it, and I think it can take a long time to develop those that relationship. And as Joy and Amy both spoke to, there's trust that we can develop and we should develop, but that comes with a lot of time and a lot of effort, and the people we're serving have to trust that we're going to honor when they walk away, when they're done, when they don't want to work with us, when they don't want to engage. And they need to trust that the goals we're developing and moving forward to, both the direct consumer, the child or the person that we're serving directly, and the indirect consumers, those caregivers, educators, other professionals we're serving with, that the goals we develop are going to be functionally, they're going to be based in the context of the skills we're developing. So I guess the last thing I'll say in relation to that is we need to move away from compliance-driven goals as a field, and there's really no reason for them. Compliance is really based in these authority-driven models, and there's almost no goal I've ever heard of where somebody said, we're engaging in compliance goals for this, that we can't reframe that as cooperation, engagement, or safety. And those skills are ones we can then build from. They don't create a ceiling like just straight compliance does. That creates a service ceiling. But if we focus it in something where we do have these large skill sets we can then develop and work with around those areas of cooperation, engagement, and safety, while teaching self-advocacy and honoring consent, then we, I think, can feel much better about the practice we're engaging with. Our field has a tremendous way to go before we're even part of the way there. But I strongly believe that we can get there, and that's something that we need to all be focusing on.
So I guess I would just like to say in closing, thank you for including me in this really fascinating, important conversation, and that I would just recommend to ABA practitioners to just approach every child and family with an individualized program, and not just go in with your ideas about what are the skills that should be taught and how to do that. And also to recognize that, there are all different types of ABA that have, or techniques that fall under the umbrella of ABA, and they have their different applications. And there are some behaviors or kind of issues that individuals might be facing that are actually beyond the reach of behavioral intervention, and to recognize those moments too. And other types of maybe more medical interventions might be necessary. And I'm thinking here of really acute, aggressive and self-injurious behaviors that might really benefit from some medical interventions. And again, thanks. This has been great.
A big thank you to all of our panelists for all of your time and energy. This is, it's exhausting, right? To tap this deep and to be so vulnerable. And so I really appreciate everyone who was willing to do that today. And for those who also maybe step back and center the voices of people who needed to be censored. And I think that was, we created space for a lot of different perspectives and a lot of conversation today. And we want to be able to continue that conversation. So we are a touch behind. Why don't we break until 2:50? So that'll give us a 7-minute break. And then you'll be randomized, as long as you're here in the audience, you'll be randomized into a discussion group with an assortment of leaders. So it's a random assignment. And as long as you're here, you'll be in one.